Good evening, councillors, ladies and gentlemen. I'm Councillor Sophia James. I'm the Chair of Adult Social Care, Children's Services and Education Committee. I'd like to welcome everyone to tonight's meeting, which councillors are now required to attend in person following the expiry of the Coronavirus Act regulations, which permitted online meetings. We're meeting in a socially distanced layout in the council chamber with a small number of seats provided for the press and the public. We'll be using new equipment connecting the chamber into Microsoft Teams meeting. There is a live stream available through Teams, and a recording of the meeting will be uploaded to the website afterwards. First up on the agenda, we have a short presentation from Richard Harrison from the Reading Advice Network.
Councillor James and committee members, good evening, and thank you for this opportunity to talk to you about the Reading Advice Network and our member organisations. The network was set up 6 years ago with some initial funding from the early charity. We try to do three things: improve the quality of information and advice available to people in Reading, make it easier for people to get the advice and information they need, and be a focal point for information and advice services. To the best of my knowledge, we're the only such network in the country. Back in 2016, working with the council, we developed our own quality standard. It's easy to revise when necessary, so last year we updated it to cover staff and volunteers working from home. Reading Voluntary Action funds an independent assessor who helps our members to achieve the standard and assesses them against it, using money from the organisation development contract you have with them. As a result, unlike other national quality standards, assessment costs our members nothing. The conditions for membership of our network are simple. Organisations must give information or advice to people in Reading. They must commit to achieving our quality standard and the good governance standard, Safe and Sound, developed by Reading Voluntary Action, and pay a £30 annual membership fee. We run two main activities: regular advice forums, which are open to members and non-members alike on issues of common concern. On the back of the sheet in front of you is a list of the topics we've covered. Each forum lasts a couple of hours, and we divide the time equally between speakers and group discussion, so organisations can share ideas and good practice. We also run a peer support group for member CEOs. We keep our members up to date about developments that could affect them, such as your Closing the Gap funding programme. We publicise their services through our website, and we give them a collective voice in situations such as this. As you can see from the sheet in front of you, we currently have 20 member organisations who between them provide a wide range of services in addition to information and advice. In November, I sent each of you a copy of this Information to Councillors booklet, setting out the services our members provide. It's designed to help you quickly find the relevant sources of specialist information and advice for constituents who come to you with problems. I hope it got to you all, that you've had a chance to look through it, and that at least some of you have found it useful. I have some spare copies with me if any of you would like them. The suggestion for that booklet came from two of your fellow councillors, Rachel Eden and Adele Barnett-Ward, during the advice forum we held earlier last year on strengthening links between Reading councillors and Reading Advice Network members. We shall update and reissue that booklet each May at the start of the civic year. That's probably enough about the network. I'd like to say a bit now about our members, how they operate, and the contribution they collectively make to some of the most disadvantaged people and communities in Reading. As you'll see from the sheet in front of you, they're very varied. Some, like Citizens Advice or Age UK, are part of national organisations with a mixture of constraints and support that involves. Others, like Communicare, the Welfare Rights Unit or the Mustard Tree, are unique to Reading. Almost all operate with a mixture of paid staff and volunteers. Volunteers, of course, while unpaid, are not free. They have to be recruited, trained, provided with equipment, supported and supervised by paid staff. Our members' operations are overseen by trustee boards, another group of volunteers drawn from a wide variety of backgrounds, who carry the ultimate responsibility for their activities. I'm proud of the contribution our members make to the people of Reading. In the last 2 weeks, 12 of our members, just over half, have been able to provide me with information about their operation in the year just finished. Although it's not a complete picture for the network, I thought you'd be interested in what it showed. Those 12 members gave information and advice and provided a wide range of other services to nearly 16,000 people. That help varied from a single phone call to sustained support over several months. They managed to secure, often through lengthy and complex casework and persistent advocacy, over £4 million in additional income for their clients in the form of increased benefit payments, reimbursements, debts written off, and so on. They achieved this through services provided by nearly 300 paid staff and over 650 volunteers, almost all part-time, many of whom have been working from home through the disruption caused by the pandemic. You provide important funding to many of our members. In 2021, your funding to those 12 members totaled just under £1.7 million. But they managed to secure a further £2 million from other sources, more than doubling the support they were able to provide to the people of Reading. As has been true for everyone, the last couple of years have been pretty difficult, and the challenges for our members remain intense. I'd like to just highlight 4 of these challenges. First, securing funding is a constant preoccupation and takes a lot of time and effort. A recent analysis suggested that only about 8% of applications to trusts and foundations are successful, and a lot of funding is tied to specific service delivery, with tight constraints on overheads. But only if they can finance their core operations will our members exist to provide these specific services. Second, some of the services they provide to generate income, such as lunch clubs, are still having to operate well below pre-pandemic levels, often because of social distancing requirements in the available building space. Third, many members report increased and more complex demands, almost certainly, at least in part, because of the impact of the pandemic on the most vulnerable. 1 or 2 of our members are finding these demands overwhelming at the moment. Finally, and unsurprisingly, many of their staff and volunteers are by now pretty tired, and recruiting good new staff and volunteers is difficult. But all of our members remain totally committed to supporting those in need in Reading to the best of their ability. Several are trying to expand their operations or set up new services. They want to work collaboratively with each other and with your services, wherever that will mean more effective support for their clients. Together, we want to be a significant part of the solution to the problems facing Reading's people and its communities. Thank you. I'd be happy to try and answer any questions you have for me.
Thank you very much for that presentation. Great to hear of the amount of people who've been supported by the network and those outcomes as well. This is an information item, so there are no decisions to be taken, but do we have any quick questions? We can take 1 or 2. If not, that's absolutely fine. Councillor Hoskins?
Yeah, thank you. I do have a question. So it seems to me that the work that your members do is obviously far-ranging and really, embedded within the town. And by nature of that work, one, you've got a lot to provide in terms of the supporting advice, but also in terms of the kind of information or knowledge that comes out of that would be really helpful for us when we, as a town, not just the council, as a town, develop strategies, policies and addressing the challenges that we face. So I just wonder if you had any thoughts around what we can do to exploit that more, to involve that more? Or, certainly it's an ambition of ours that when we're developing strategies, we're very much producing those collectively across people within the town. So I just wondered whether you had any ideas in terms of how we can improve that aspect, particularly with your network and its members.
Yes, I think one way is you're already moving in this direction, which is the review of the link between the council and voluntary services, which I saw this morning for the first time, emphasises the importance of trying to build closer relationships between the council and the voluntary sector. And I think the more effectively we can do that, the more likely it is that the knowledge and information we have and the knowledge and information that your staff have can be better integrated to provide really good support for the many people in Reading who struggle with the pressures they're under and the financial difficulties, etc. So I think the closer we can build relationships, the more effectively we will jointly support people.
Thank you very much. Okay, I see no further questions. So, Councillor Ennis.
I think we need to really pay tribute and total respect to the Advice Network and the great work that you're doing and these member organisations. I think it's total appreciation for the voluntary sector, and we have to put on record that without these organisations and many more, then this town will be far worse off. I mean, I've had the privilege of my time as a councillor for a number of years of working with many of these organisations, and quite a few over the period, and I know what they do and the dedication, the total dedication and public service working with the voluntary sector, going out of their way to help is second to none. And I think it's a total credit to the town of Reading, because a lot of these are Reading specific charities. We've always been vibrant with the voluntary sector. This council, when we do need to improve our cooperation and working together with the voluntary sector, has a history of funding the voluntary sector over a long number of years. Even in times of austerity, we still felt it as a priority to ensure that many organisations in the voluntary sector would get funding to assist. And what we can't do as a council, these great organisations step in and help. I was going to name a few, but I don't think it'd be unfair to name them because they're all brilliant in their own way. And we do need closer relationships. I'd like to think we've got a good working relationship at this moment, but we can always make it better, and we can always make it where they feel part of working together under the vision that Reading have. So I really do put on record, thank you, your organisation, the network, and please pass on total appreciation and thanks for what these organisations do for the people of Reading. Thank you.
Thank you very much for that. I think it's particularly been as a result of the pressures of the pandemic that the relationships, the working relationships, both at grassroots and at a more strategic level, have developed so much over the last 2 years.
Thank you, Councillor Ennis. Councillor White.
Thank you, Chair. And yeah, thanks for the presentation. It was really informative. And yeah, good work as a councillor. I know that there are 1,000,001 things that are just really tricky issues, and I'm sure all of us are always signposting people towards all of the really great organisations in the network. I was interested in how issues are changing at the moment. For example, with the energy cost crisis, I was wondering if you were starting to see people coming through the doors of some of the organisations in the network with that as a concern and an issue people needed help with.
Yes, it's growing for a number of our members, and it has been around for some time, but some of them are now finding that the demand is going up quite sharply. And I think will continue to grow over the rest of this, certainly the first half of this year, as we all recognise what's going to happen to energy costs. So.
Thank you very much. Okay, there's no further comments. Richard, thank you so much for your time tonight and for acting on behalf of the members of the network. I think we can all agree they do phenomenal work, and we're extremely grateful for the work they do to support residents. So thank you very much for your time.
Thank you very much.
Okay, on to item 2. Are there any declarations of interest? I see none. Item 3 is the minutes. Are we happy to agree the minutes? They are agreed. Item 4, the petitions. There are no petitions and no questions from members of the public or councillors this evening. Item 6, there are no decision book references. So we move on. We have some colleagues from the CCG to discuss the review of same-day healthcare, and I believe we've got Katie Summers on call.
Hello, Chair. Thank you very much, Councillor James. I'm joined today also by Dr. Andy Czachesky, and we've also trying to get into this meeting Sanjay Desai, who is actually the interim head of primary care. I'm hoping that he's just come on board now, so he's joining me in this actual item. I'd like to first of all thank you all for inviting us to come forward. I'm hoping this will be a very, very enlightening conversation for the members, and actually would welcome any questions going forward. I will actually make the members here know that actually I might have to drop out. I'm struggling with childcare of a 7-year-old, so I have to put him to bed. So I'm sorry about that, but I'm sure Dr. Czachesky and Sanjay will be able to cover for me as I put him to bed. You presumably you've got a copy of the presentation, but I will share this on the actual screen now. So let me just make sure I can load it up.
I'm sure we're all familiar with the challenges of home working throughout the pandemic, so
yeah,
no criticisms here.
That's great, thank you. Right, let me just put it on full screen. So we are going to do a bit of a triple act here with this presentation, because sometimes you get a richer context, especially from a GP. So obviously you wanted us to give a bit of background about what was happening in the walk-in centre. At this point, I'll hand over to Andy, because he has a really good understanding about what's happening on the walk-in centre at the moment.
Yes, thank you, Katie. Good evening, everybody. Andy Czachesky, I'm a GP at the Emma Green Surgery. I'll list all my conflicts of interest at the same time. I'm a clinical director of the Caversham PCN. I'm an urgent care lead of the Berkshire West CCG and vice chair of the Reading Health and Wellbeing Board. So cover quite a few aspects of care across the patch. The Reading Walk-in Centre, those who have a long memory, was opened back in August 2009. It's hard to believe it's been around that period of time. It's developed over that period of time in many ways in terms of the facilities that they've got at the Broad Street Mall. Prior to COVID, the walk-in element of the service there was commissioned to provide approximately 38,000 walk-in appointments per annum. Prior to COVID, we were already looking at the service because it wasn't actually seeing that many. There were lower numbers. Off the top of my head, it was sort of in the low 30,000s, so they weren't seeing the capacity that they had. We were already looking at, was it an efficient use of the commissioning amount of money that was being paid for the service. Due to COVID, it's a primary care service. It's not an A&E department. So it had to take on the same form of working as everywhere else in primary care. We had to do triage first, which was telephone first contact with patients, and then seeing them face to face if clinically appropriate. So the walk-in service for its obvious infection control reasons had to be suspended. The surgery that is based at the walk-in centre actually moved to a neighbouring surgery for the start of the pandemic, because the walk-in centre was actually repurposed as our Reading respiratory hub. As they got back to business as usual, around July, I think it was, of 2020, The routine surgery work returned back to the walk-in centre and has carried on as all other surgeries have, with telephone contact, face-to-face contact, doing all the normal work of a GP surgery, which has increased and surpassed what we were doing pre-pandemic. Obviously, the pandemic's lasted longer than we expected, so all the discussions and plans around, the changes to the walk-in centre had to be put on hold. The two aspects to the reprocurement of the Reading walk-in centre, there's the walk-in element, as I mentioned, and also the registered list element. And it's interesting that over time, and this was probably what to be expected, the surgery has grown in terms of its registered list from nothing when it opened in 2009. And at pre-pandemic times, January 2018, I'll give you some figures. It had 8,200 patients. In January 2019, it had 9,600 patients. Just before the pandemic started, it was in January 2020, they had 10,300 patients. In January 2021, interestingly, they had 10,180 patients. And of January 22, they're up to 11,053 patients. So apart from a little blip through the first year of the pandemic, their numbers have been rising. I think there's probably an element of increased list sizes. I haven't got all the data to hand across quite a lot of the central Reading practices, because there's also an increase of patients in central Reading. There's an increase of new housing. I was driving through Reading myself just the other day with a lot of the new buildings and flats being built at the Huntley Wharf area. And there's a number of areas around Reading which are sort of infilling with new residential housing. And we know that that's within the plan for Reading over the coming 10, 20 years, that there is a plan for all the increased residential. So all the residential housing. So there's definitely going to be an increased pressure on all the practices across Reading with increased lists. So going back to the Reading walk-ins centre, the name's a bit of a misnomer now because it's not a walk-in centre. That's its historical name. It happens to be in the Broad Street Mall. As part of the reprocurement discussions, we were talking about what would be the most appropriate name for it, probably Reading Central Medical Centre or something like that, because it is very central, and that's why a lot of people tend to go there. Because of the pandemic issues, the actual reprocurement exercise has been put on hold. Because they have a contract, it had to be extended. So it's got an APMS contract, and that was extended until March 2023. The challenge for the CCG team will be that it does take time to reprocure these sort of services, and also if you're doing a major change, such as taking away a walk-in service, there has to be an element of public consultation, and all of that was being planned pre-pandemic. And obviously that's going to have to be revived, hopefully, as we come out of this latest wave of the pandemic, which has caused a lot of pressure on everybody. CCG staff are still being repurposed for helping with vaccination and dealing with the current challenges. So at some point, in going into this new financial year with the view of March 23 as a deadline for reprocuring a service, both the walk-in element will need to be looked at. There'll need to be a public consultation exercise, and then a reprocurement either of the walk-in element or a commissioning decision that actually the walk-in element is no longer required. The things that I will put out there, which aren't on the slide, which are just thoughts, that the pandemic has changed the way primary care works. Not everybody maybe likes it, but that's how it is with the pandemic. It has pushed the digitalization of how we do things in primary care and the alternative ways of consulting in primary care, probably to a degree in a rather dramatic way that we didn't expect to do it pre-pandemic, going from triage telephone calls as we still did already at the time, ringing patients to discuss a problem when they wanted a phone call back, to actually having to deal with everybody on the phone first, was a big change, not only for patients but for the GPs. Doing online consultations as well, whether it's using text messaging, whether it was using an online chat system, which is a bit like emails going to and fro. I'm doing video consultations. You know, we've all had to adapt and do things differently. Now, unless you are not digitally connected, which I appreciate is an issue, if you haven't got a mobile phone, which could be an issue, if the only way you can make contact with somebody is by physically seeing them face to face, there'll be a minority of our residents who should be able to find a method of contacting their GP one way or another. The question is, how many patients need a face-to-face contact as the first contact, because there's no other way of making contact with a surgery, whether it's online, digitally, or by phone. So I'm just throwing out, you know, that as we come out of the pandemic, there'll be a lot of reflection on how we've changed our way of working. What is the new primary care offer going to be as we come out of it? Because we're still under the NHS England triage first rules at the moment. I mean, we're all hoping to come out of the pandemic soon and go back to some form of normality. But what is the new normal going to be? It'll be a hybrid of what we did before and what we've learned to do through the pandemic, which has, for many patients, offered more options than they had before. It's been more convenient for more patients. A lot of my elderly patients like to be dealt with on the phone because it saves them a very complicated trip with either 2 buses or a daughter having to come from far away to drive her to an appointment, to be able to deal with the doctor on the phone instead. So there are pluses and minuses with everything we do, and it's going to be a big discussion to decide which way the pluses and minuses fall as to whether we need a walk-in service going forward, or whether primary care, in the way it's reconfigured going forward into the future, and the future offer of primary care will be what will be needed for our residents of Reading. Sanjay, have I missed anything from the Commissioner's point of view? I've given the sort of GP sort of Commissioner slant, but you're closer to the commissioning aspect of it.
No, I think you've covered everything actually, Andy. I think everything was, yeah, you've said it very well. Thank you.
Thank you. In which case, any questions from anybody?
Andy, maybe I'll just carry on with the presentation.
Okay.
And then, yeah.
I think it would be better for us to get through the presentation and then ask questions.
Okay,
Thank
so
you.
I'll just take over from now, but obviously Sanjay and Andy can chip in. The second thing, obviously, that you wanted an update on was actually what was happening following the vaccination canvassing exercise. So this is a big thank you to Reading Borough Council, because last year I stretched out to Peter Sloman to say, could he help with actually doing some door knocking of certain homes where the GPs have been stretching out, trying to contact those homes, but actually they were unable to actually establish contact. The individual GPs actually shared the contact details of those individual homes, and your canvassing exercise actually visited 1,189 households, and you did that quite rapidly. You did that between the 29th of June and the 9th of July. Now, what you established there was the fact that around about 22.1% of those patients were no longer at that address. We then shared the actual list of those individual patients who are no longer at their at that address and actually needed to book a vaccination. We shared that analysis back to the actual GPs, and the GPs were asked to actually cleanse their lists in order to actually ensure that those names were actually taken off the support. Data was also analysed by your colleagues at Reading Borough Council and sent back to the GPs as well. So I think this has been an exercise of benefit from the point of view of not only the GPs, but I think also it's been a bit of a cleansing exercise for Reading Borough Council to know what's actually happening on your individual lists of, for example, adult social care, as well as also council tax. So a big thing to note here, it should also be noted that when we lost my presentation, where's it gone? As it should be noted that when we actually did go round and they actually visited the actual work, we did the investigation, and 53.1% of the total household visited did not respond or answer. So again, that information was also shared, and actually we're hoping that actually that has been list cleansed as well. We'd also asked about what was happening on the actual data of the GP information system as well as the ONS populations. And it's worth noting that there may have been overcounting in GP practice registers, because obviously some patients might be ghost patients as well as students. There may have been undercounting in the population estimates because associated with the census completion and inaccurate estimations of integral migration. Obviously, when we looked at the data of the GP and ONS, we can only go by the ONS, which is now over 10 years out of date. So obviously there is a bit of miscounting going on here. And equally, the different definitions of who counts as residents in the actual country was also a bit of not necessarily quite clear going forward. So the data that we are generally using at the moment is generally the GP data as opposed from the ONS populations. So one thing I would say is during a meeting where this was discussed between the CCG and Reading Borough Council officers, we did identify notable differences, though, especially in relation to men. And this was actually who are in the age groups who have not been identified for screening programmes. So that was in relation to two specific areas. That was Leighton Park, which identified obviously the 25 to 29-year-olds, which could have been included for ex-students who have moved on. And equally in the Kennet Island, 35 to 39, which is a very transient location for social housing. This obviously information has also been shared to the individual practices associated with those areas and asked them to double check what was actually happening on those areas. Following, we've done an internal review, and the CCG is taking the following actions with the GP practices. So we're asking them about how confident that they are that their registers is more up to date than the ONS data, and equally we're asking them how many patients have not wanted to take up their vaccination appointments. Now, this is a key thing to note here, is the fact that on the vaccination programme, which I'm the overarching lead, the actual key thing to say is most of these GP practices are contacting their patients who haven't come forward yet around about between 6 to 7 times. And actually, if they do get an actual non-response, they log that and actually inform us about whether or not we cannot get hold of anybody. But in most cases, they are getting hold of people, but the people there are saying to us either the fact that they've got COVID, either they're trying to get a walk up, or the fact that they're not interested in actually getting a booster. Next was a review of individual practices in Berkshire West with regards to the list size and the growth. So we have identified over the past couple of months that data on registered list size and a comparison between August 2018 and 2021, we've seen an increase in the registered list size of 7%. Now, what we're doing here to support this is on several layers. So we've asked the CCG primary care team to contact all practices identified in the report that we've undertaken, which Andy referred to, and as well as also the patient practices where households were registered who have been visited for the canvassing team, and ask them to verify their list going forward. we've asked them to provide assurance that what they're doing on their list maintenancing processes, and they're following what's defined within the GP contract and this procedure, which is called FP69 procedures. That review is currently being undertaken, and actually we're still waiting the outcome from that. Many practices reported, in addition to the regular list maintenance reviews, that there has been a clean-up after COVID vaccination invites has been sent out, which obviously I've referred to. On the list cleansing of the males, which obviously we've said here was very much about that younger population between the 18 to 49, which will be a very hard process to do. One thing that we are looking at is actually how's the best way of undertaking that. And Andy's referred to that list growth at the moment. Literally this week, we've spoken to some of the Reading PCNs, and they've referred to the very high migrant uptake over the past year. And so what we're doing here is obviously ensuring that we do some work to ensure there's list maintenance carried out in line with the policy and guidance, together with list cleansing of those certain practices that actually we've identified. So we're hoping that actually this will kick off. Sanjay Desai, who's actually at this meeting, has agreed to deploy some of the CCG staff to help with those Reading practices where there have been high migrant uptake and support that registration, as well as doing that COVID vaccination record update. So we're hoping here that this exercise will be done quite quickly regarding those practices. They have already agreed to get that CCG support with regards to helping them with the actual list cleansing to support with the migrant population. The second thing that we've done is about investigating how we would also look to commission an actual external audit or an internal audit. At the moment, we've looked at possibly commissioning GP practices to undertake an audit. However, I'm sure Andy would agree with me here, that internal pressures that individual practices have at the moment in related to both the vaccination programme, but also dealing with the actual catch-up of ensuring they get everybody supported, especially those people that are at risk, cancers, long-term conditions, respiratory conditions, cardiovascular disease, is a huge amount of work. So it feels at the moment that we cannot ask the individual practices to do an internal audit. We have also engaged with an organisation called the Primary Care Support England, PSE, which is the only NHS-approved list cleansing organisation to run a bespoke audit to support list cleansing. We've got some initial costs from the actual Primary Care Support England. However, these costs are extremely high. So we are now asking NHS England to see whether or not there's a possibility of getting help from the national team to actually get those costs down so we could actually really support this audit going forward. At the moment, it wouldn't be cost value for the actual CCG or for the taxpayers' money, given the costs that they've provided. The next is about an update about what was happening on the actual GP access regarding GP appointments. And now Andy has actually referred to this already. As a CCG, we hold the contract for 45 individual GP practices. And as a CCG, our role is to provide advice and guidance, and obviously ensure the individual GP practices are following the guidance, the actual contract specifications that set out to them. So it's fair to say that most of these GP practices are doing their utmost to support the actual getting as clear as possible, as many people access to GP appointments as possible. Now, I'm just going to refer to Andy here because Andy put this into the actual details for me. So Andy had said if a patient wants an appointment, they obviously be offered a GP callback. This is what was deemed to be a proper appointment with a GP. As Andy was saying, this is that triage first model which NHS England have stipulated. And this is here to discuss their medical problems. Some possible issues may be that their work during the normal GP opening hours and cannot receive a call. Now, previously, they would have booked a face-to-face appointment at that time, and they may not have been able to attend, especially for those people who are working age. Now, the individual GP practices will be able to offer a phone call, which actually can be done at a fixed time or in a roundabout time, and that phone call lasts for 10 to 15 minutes. So that actually gives them much better access to an individual GP as it is at the moment, rather than having to take time out to go and visit an individual practice. Equally, one thing that most of the practices are doing is they're also asking about what specific windows that the individual patient is wanting, and they ask them, do they need to be flexible? So as Andy put here, if you are a teacher, all practices try to accommodate this. So they won't be asking, could you call back between the hours of 9 and 4? They will ultimately try and offer an appointment when they know that individual teacher would be available to take a call. And they do this for most occupations themselves. They're much more flexible with this approach going forward. So as Andy was saying, the actual triage model is what's being commissioned at the moment, but obviously that's being reviewed at the moment, and we're still waiting to see what the guidance is coming out from NHS England about what should be taken forward. Is there need to be going back to face-to-face appointments? Is it about sticking with that triage first, or is it going to be much more of a hybrid model going on? So that was the end of the presentation. I think that actually we're happy to actually receive any questions from the members. Obviously, if this is okay now, Chair, I'm going to put my little boy to bed. I will be around and I'll come back hopefully in about 20 minutes. But I'll leave the questions to Andy and Sanjay.
Thank you very much for the presentation. And I think we can all agree that the NHS has done a pretty phenomenal job during the pandemic. I'll hand over first to Councillor Hoskin.
Yeah, thank you very much, Chair, and thanks for this this presentation, answering some of the queries that we related over. I think I'm going to do two things. I'm going to sort of propose something in terms of taking this forward. But also just sort of some personal some reflections on it. I mean, I think one of the things that's not said here is that a lot of the issues that are coming out and a lot of the people's experiences of trying to access same day, I'm particularly thinking about accessing same day appointments, trying to get some medical advice, maybe you speak to a GP, really does boil down to the fact that primary care services are so stretched, not just in Reading, but across the country. I mean, I've been at a meeting, I think it was actually Dr. Czerski was presenting information in terms of the increased level of activity within our GP practices in Reading, and more appointments, more referrals, more work being done. I don't think many people necessarily appreciate that, but of course there aren't actually, despite promises, there aren't the increased number of GPs and staff available to do that work. So it's a real, system under a great deal of strain. And on that basis, I think a lot of the people's frustrations, like we've got the 8 o'clock desperate attempt to try to get through to a practice. There's quite a deal of variation between practices and how they work. I realise they're independent practices. I realise they can go off and do their own things, but what we can do to try to work through best practice and variations in terms of accessing by what the policies might be, but also real variations in terms of quality of things like websites. That I hear about the ability to connect to practices via that as well. I mean, certainly I also get back that there's a lot of things that are easier. So you might not speak to a GP rather than have to traipse in to meet them can be absolutely the right thing to do. But people are also frustrated about the ability to actually get a face-to-face appointment. And also, I don't think we should underestimate the issue of the callback. Whilst it's absolutely right, you may only have to be available 10, 15 minutes. You happen to be working a long shift as a truck driver or as in Tesco's or whatever. It may be very, very difficult to be available for a telephone call, whereas you would have been able to take some time to visit GP practice. So I think there's a whole load of issues around how how same day access will look and how we make that work for the people of Reading. So one thing, there is a review. I'm not totally sure of the status of the review. I'll get the bit about the decision on the walk-in centres being put back a year. So I think there's less of an urgency about our input into that. But certainly as a council, I know I've spoken to colleagues, we do want to be involved in that. We want to input into that review and to give our views. They're taken into account. So what I think, it feels to me, and I'd like to propose, is that we do commission a report in terms of that review and the elements like I'm talking about, because I suppose, so it's about the walk-in centre, it's about how people access primary care, it's about dialing up access, the NHS line. It's about things like minor injury clinics, and also it's about like A&E and how all those things interconnect. Because if we make things harder for people to get same-day access to primary care, we know there'll be an overflow into A&E. And then a question that I'd really like addressed, if we, from that report, is what is happening to those people that did access a walk-in centre element to the walk-in centre? It wasn't an inconsequential amount of people doing that. What is happening to those people within the system? How are they being supported? Are they presenting any unnecessarily, or are they being supported elsewhere? So that's my proposal, because I think there's a lot in there, and I think if those considerations, if that review is happening within the CCG, or if that's being expanded out in Bob, I was sort of a little bit sad to see the Bob logo on here, as someone who has over the time has seen the decisions with the NHS move further and further away. That's slightly a little bit sad to see, but it's what we want to do is to be, as a council, to be part of that review. So I'd like to propose that, and that comes back to a future meeting, ideally the next one, but I guess it's where it sits within the process of your considerations as well, so that when those proposals start to come through, you can see that we had that input into that, and we've been listened to, and we can represent the views of the people of Reading.
Thank you, Councillor Hoskin. I'll take any comments back and then we'll deal with the proposal.
Andy, please chip in. But we're happy to do that, Councillor Hoskins. What we can do is, Andy chairs the group that we'll probably be looking at anyway, actually. So we're just trying to get a project manager in to try and support us with the whole procurement exercise, because this is going to be quite a big job. We'll make sure you're involved in that. That's no problem at all.
Thank you very much. In that case, has everyone agreed that we'll commission a report back? Lovely. Okay, onwards to questions. I've got Councillor Carnell and then Councillor Terry. Councillor Shikali as well.
Thank you, Chairman. Thank you for a very informative presentation. You say you're getting 30,000, or you were getting 30,000 walk-in appointments. That is 82 a day if you're open every day of the year. What sort of conditions would merit a walk-in appointment? Thank you.
Any condition that a patient can walk in with, literally. That's a prerequisite of being a walk-in patient. It can be anything from a minor cold to somebody who's got, intestinal obstruction potentially if they're still mobile. So, it can be anything from a minor ailment that can be seen by a nurse to a major condition that needs calling 999 and transferring straight to hospital. So there's a lot of variability, same as you have in any general practice.
Okay, Councillor Terry.
Thank you, Chair. A couple of comments as well as a question. Actually, I would just reflect that 30,000 figure that Councillor Connell just mentioned, is that you said 38,000 was the sort of target. Well, 30,000 seems pretty close, actually. It's certainly not, if it was 20,000 or if it was 10,000, that's a significantly less number than was accessing it. But at 30,000, it sounds like there's a demand, there's a need, and there's definitely in the review that needs some very serious consideration. The comment is that we're planning to take away the walk-in service. Well, let's plan to see whether actually there's a need to continue the walk-in service that might need to be redesigned in light of other things, and certainly the pandemic, and certainly in terms of actually the register that's being created there. And that's that's a challenge for all of us. It's a challenge for the country. As Councillor Hoskin said, there's just not enough of you GPs. We really love you and we like to have more of you. And, so don't go away thinking I think anything other than that. But if you have a very strong economy, you tend to have lots of transient people coming in and out of that economy, and they, you won't keep your list clean, if you've got that transient population, but you might keep it cleaner if they have a walk-in service, so they don't have to register and they can walk in and get something. So I think I just want to make that comment again, just to say that it needs thinking about. I was on the phone to a constituent only yesterday who wanted to ask me, as an elderly constituent, why Reading Borough Council couldn't get a GP practice nearer to, he was having problems getting access, he was finding it difficult, but he understood the practice was perhaps not overwhelmed, but certainly had a lot of people on its register, and why couldn't the council just get another GP practice in the area? And, I'd remind him that whilst we appreciate the relationship you have with the NHS, actually GP practices are not, in fact, that they're private organisations, etc., which makes the relationship even more complex at times. So I just want to point out that, in terms of the council's involvement, we get these sorts of questions from our residents. They think that we somehow can just, if we're planning housing, we must surely plan the GP practice, and that makes absolute sense, and yet no, that's not really where we tend to be. So if we're going to have an integrated care system in this country, let's make it a really integrated care system where the people like us who are planning and have to agree the housing, because the government's legislation more or less tells us we have to accept most of it, can actually also have some much more interaction in terms of what services and infrastructure should be there. So that was sort of some comments. I have a question, Chair, if you'll just indulge me a little further. I didn't quite understand in the presentation the issue about would like to undertake immigrant checks as part of the extended programme. I just wanted to understand a bit more what that was about. I mean, we can like to think of ourselves as a welcoming town, and we know that people do come here. We have an Afghani community, there's other things that happen that we receive people who are coming in and creating new communities, which we very much welcome. We tend not to call them immigrants, tend to call them new communities and welcome them, but I didn't understand what that exactly meant. It's in relation to cleansing in one hand, so is it just because it's transient, people come in and go out, or is there something very specific about that I didn't understand and I'd like to understand better, please?
Yes, Andy or Sanjay.
From my point of view, I think it's not about immigrant but migrant, as in transient people that come into the Reading, maybe stay for 6 months and then they move on again. Nothing to do about their ethnicity or religious belief or anything like that. We know that we have had new communities coming into Reading from rather impoverished parts of the world, which have been we've had to deal with those challenges, and those patients are welcome as residents of Reading and as patients of our practices. Just reflect, I've got quite a lot of Hong Kong patients now in the Caversham area for some reason. We're more than we had before. There may well be pockets of Hong Kong patients across the whole of Reading, I don't know. So there's patients coming from all parts of the world and they're all welcome. Sanjay, do you want to, it might be just terminology, I think, rather than anything specifying a specific community.
Yeah, no, I think you're absolutely right, Andy. It is the transient patients. So obviously, if those patients are in our area, they'll register with the GP practice. If they then leave after 6 months or something, they're still, unless they advise the practice accordingly, they're still left on the list. So when we come to start looking at sort of vaccination rates or anything like that, it's going to look as if our rates are lower because those patients are on there. So it's really just making sure that the patients we've got on the list are clean, for want of a better term, and it's absolutely the transient patients. So it was terminology, I think, actually.
Would you like to clarify?
No, if that's what that really means, immigrant is being used in a different way about migration of people from town to town within the country sometimes, as well as, from other countries, maybe that's fine. But I think you need to really look at the way in which it's written down. It almost sounds like a check to see whether people are on the list that shouldn't be on the list because they're not entitled to access services. And we would be really concerned if this process was about that. We'd like to probably have further conversations about, and you know, we all know about no recourse to public funds. It's a very tricky issue for us all, in terms of the government legislation and our ability to use public funds on people and et cetera, et cetera. But I think if it meant anything else outside of this meeting, I think there should be further conversations.
And just because I'm going to go over to Councillor Chicago, because I know she's got a question on this, but what the document actually says is Berkshire West CCG would like to undertake immigrant checks as part of an extended programme of list maintenance. And then it goes on to say that the CCG is redeploying staff to Reading practices with high immigrant uptake. So that's what we're looking for clarity on. I'm not sure that answer really got to grips with the question.
Yeah, no, can we come back to you? We'll absolutely clarify this and get it absolutely right. I mean, the point about the CCG being deployed was we had meetings with the Reading PCNs this week, and they just flagged that for some of their vaccination rates, they had patients on their list that didn't live in the area anymore. I think it is a terminology thing, but we'll definitely get clarity. We'll come back to you on that one.
Councillor Chicago?
Well, I won't dwell on that point much more, but I think we all have concerns that sound rather hostile, so we're keen to hear more about that, and maybe that'll come back in the report. But going back to the start of your presentation, just one point I want to pick up on, a query. You're talking about the registered list size between August 2018 and 2021, showing increases in 7%, but you talk about your previous iteration of your FP69 procedure. Is that actually before, after? So that's with a list cleansing, and you still have a 7% increase. Is that the case? Your slide 5 for clarity.
Sorry, can you just, sorry, I can't, I'm having IT problems. Can you just repeat the question again? Sorry.
Yeah, sure. So basically, this is on your slide 5 under area 6. C, you talk about your registered list size between August 2018 to August 2021. It's talking about an increase of 7%, and obviously you've gone through your presentation, your 8k increase to your recent 11.3k increase. But I just wanted to understand if that 7% increase is still after you've done your last FP69 cleaning of your lists.
We haven't yet. I'll need to double check. I'm so sorry about this, actually. I will check with Katie. Hopefully Katie might come on again, actually. I will check with Katie about that. Apologies for that.
Thank you. I can come back to the next committee. That's fine.
We've got another question from Councillor Mpofu. Oh,
not done.
Councillor
One more
Shkreli.
question for me, and I'll move on. Thank you, Chair. So obviously we're so glad that you've been working really hard throughout the pandemic, and we're going to start looking at evaluating what we do in the future in terms of delivering traditional care to what happens in the future. But in this evaluation, we'd be looking at the effectiveness of the phone service it's been offered throughout the pandemic. Because I know that Katie gave out the outline of the convenience that offers for people who are working, of working age, and fitting in their schedules. But one of my concerns is that are we evaluating this in basis of the numbers of appointments and the number of people who try and get appointments, getting appointments, or are we evaluating in terms of the outcome? So the value that the patient gets in terms of their case being resolved, their issue being resolved. I would really want us to look at what the key performance indicator is and what the success outcome is, because there is numbers and everyone getting appointments at 15 minutes long, but there's actually making sure that key issues, health issues that maybe would be picked up in a face-to-face traditional appointment aren't missed while we look in the future, because now the pandemic's easing and we move to endemic or whatever happens in the future. How do we deal with this issue and make sure that people get the best quality care? Thank you.
If I come in from a GP perspective, I'm certainly not going. I'm not doing that sort of measurement. There's no KPIs in general practice. There are some KPIs amongst some of the APMS practices, possibly as to outcomes. I don't think that sort of outcome will be in a KPI of any sort that I've seen. Whether NHS England is doing any of that sort of work across the country. Obviously, as part of, as you say, pandemic changes, is I'm sure there's scope and maybe a need for doing that sort of an evaluation. It would certainly need to be done at a much higher level than anything that we would do just within Reading. I think the the intricacies of having to run some sort of an evaluation would be beyond what we could do here locally. I mean, I've said this to many of my students and young doctors and even colleagues, and this might help a little bit, is that if you're registered with a GP practice and you have a medical record and you have a relationship with the practice, we're providing your regular medication. You come to us with your problems, which we can document, we can work on, we can investigate, we can refer on, we can find out what the results of those investigations are. We build a picture of a patient's health record. Whether you see the patient face to face or whether you're dealing with them digitally, we still look at their health record. And back in the old day, it would be lots of little cards in a Lloyd George wallet. As we developed, A4 pieces of paper, they would have bigger files. And then in 2000, practices started to digitalize their records. And since I've been in my practice since 1999, I actually instigated digitalized records. So it's all on the computer now. So we don't write in paper records anymore. So whether you're face to face or whether you're online or whether you're on a telephone conversation, you're still dealing with that patient's GP record, and you've got all that information to help paint a picture of that patient and remind you of the picture you have of the patient, because I can't remember all 12,000 patients in my practice. I can't remember, my share of those patients because we are a group practice. But the digital information helps us to get into that headspace and into that almost augmented reality of how you're dealing with the patient. And if you have all that information to hand, you can actually work with a patient virtually. He doesn't have to be face to face. Now, that may be a challenge for some people to understand. It may be a challenge for some patients to understand that. But that is where we've been going for the last 20 years. And it's no different now. What the new normal will be, as you're inferring to, have to be a hybrid of that. There are members of our communities, younger population maybe, who want to be dealt with in a virtual way. There are some elderly patients also who love to be dealt with virtually. I've mentioned that already. And there'll be some patients who can't deal with that. They have to deal with a face-to-face, and there are certainly certain conditions where you have to deal with somebody face-to-face. You need to look into their eyes to understand what they're saying. And they need to see you to have the reassurance that you are taking them seriously. I absolutely accept that. There will be a hybrid model going forward, as I've said before as well. So I'm not denying that there are challenges on both sides of patients accessing healthcare, and there's challenges for us to provide it from a general practice point of view. And I think conversations with our patient participation groups, we are able to sort of explain what we're trying to do, and the patients feed back to us, and we try and adapt what we do to make sure we have patient input to what we're doing. I think I can say hand on heart in my patch, in my practice, I think we take that feedback, and I think we provide what our patients want in different parts of Reading and different parts of Berkshire West, and it'll be different across the country. There'll be different nuances to what the offer will be. So there's no singular KPIs that will determine what primary care does, because primary care is very different, not only between individual practices, but also across areas and across nationally. So I don't know if that helps with sort of answering the question.
Thank you, it really does. And just to know, it's not a criticism of the fantastic work you've done already and the fantastic work you continue to do. Your work is massively appreciated. And thank you for answering my very, very laborious question. Thanks a lot.
I've got another councillor comment, but as you mentioned the new normal, I'm just going to jump in because I'm the chair, so I can. Because it's interesting, digitalisation can be wonderful. So I love the fact that I can book appointments online, I can request new medication online, repeat medication, and I think that is absolutely excellent. Although I must say there are a couple of examples where I've called up the GP with things like tonsillitis or a sports injury, and trying to describe over a phone where my hand or leg or foot might work is a really difficult situation. And even that my GP practice has, physios acting over the phone, where privately physios have been working pretty much all the way through the pandemic is something that I think needs to be considered. So you're quite right that some younger generations, and I hope I'm still included in that, might well want to access things kind of over the internet or digitally. But I think, you know, when discussions come around for the new normal and the consultation happens, there has to be a bit of element of choice and a bit of consideration that, try as I might to take a photo of the back of my throat for my annual tonsillitis, it's, you know, incredibly difficult to do. So just if you had any thoughts on that, and then I'll move to Councillor Mpofu-Coles.
Yeah, I think, as I said earlier on, I think the pandemic has forced us into working in a different way because of the pandemic. And in certain situations, it's been beneficial and it's worked and it's shown what is possible. Certainly not everybody can do a selfie of the back of their throat. I've certainly had plenty of pictures of backs of throat of mothers doing it for their children. Selfies are not great. Yes, there are the physical side of dealing with physiotherapy again has been challenging, and the physiotherapist, certainly the one in my practice, has had the same challenge, that, you know, having to try and work on it digitally by telephone first, and then trying to decide which patients they actually had to put their hands on to make a difference. And that's again, I think it's a perceptual problem between what the clinician thinks the patient needs versus what the patient thinks they need. And I think it's only through communication and trying to understand what each person's trying to achieve, you'll then decide, well, actually, I will accept digital information, or no, the clinician decides I do need to see them for a face-to-face consultation. I mean, my sort of take is that if I need to put my hands on a patient to examine them, and the same with the physiotherapist, if they actually physically need to put their hands on a patient to examine them to see will it make a difference to the treatment that patient receives, then that patient needs a face-to-face examination. Currently, under the situation we are in the pandemic, remember, we are still in a pandemic. As and when the pandemic is over and no one's getting infected left, right and centre, causing isolation, time off work, sickness, the reduced staffing, pressure on the service such that my GP practice has got 2 doctors working from home or actually in bed, then, you know, when we don't have that weekly threat of that stress of the pandemic affecting what we do, then we can start talking about going back to whatever that new normal will be. And maybe very rightly, as were forced by a pandemic to become digital first, we'll go back to a model of thinking, well, actually, yes, we can see patients face to face first, but then giving them the option of going digital if they want to do that. Currently, under pandemic situation, it's digital first, then face to face as the next step. So I'm not saying that what the new normal is going to be. I have no preconception of that. I'm very optimistic that this wave is the last one. I might be wrong. There might be another variant, and we might still be in a pandemic situation for another 12 months, maybe longer. I'm hoping that by this summer, we will be getting somewhere to some form of normality. I think we all need it. I think both GPs, all clinical staff. I think it mustn't be underestimated how exhausted we are from the way we're working, and because it was a dramatic change, very much like I know most of the nation is exhausted by having to live under the auspices of a pandemic, testing, isolating, all the mental health issues that are being stocked up that we're having to now deal with. I think the whole nation needs some sort of reprieve, and I'm hopeful that that will come this year. And I think we just need understanding across all sectors, across local authorities and health, that we're all in it together, and that the result that we get to will be the right one for our residents in time. Sorry, that's my soapbox. Thank you.
Yes, Katie.
Yeah, just building on what Andy was saying there, I think the other thing to sort of complement that would be, I'd like to be stretching out to Reading Advice Network, because I think that what we could be supporting is those individuals within Reading who really struggle with a digital first initiative, getting those voluntary organisations to work alongside those individuals to help them. So I do know, for example, in the past, some organisations such as Citizens Advice and also Age UK had done some work with supporting especially the elderly population, but also areas where there is high deprivation and quite poor digital literacy. I think actually we could do some more work in order working with that Reading Advice Network to actually help individual populations, individuals, in actually getting them to understand what is digital first, what is that hybrid model, getting them also to become more digitally literate as such. I do recognise at the moment that actually Reading Borough Council does have a digital literacy programme, but I think it'd be really good if we could start to link together both the healthcare services and our CCG and our primary care services with that digital literacy programme as well. It's just a suggestion.
I think that would be positive. And Andy, I appreciate your comments about how stretched health workers have been over this period. But rest assured, I'm sure the Prime Minister will organise a good party for you all when the pandemic is over. Councillor Mpofu-Coles has been waiting very patiently, so I'll hand over.
Thank you. Thank you very much, Chair. My question was more about what Katie said on the slide about GP appointments on the triage. One of the things that I probably didn't hear was the 8 a.m. rule that GPs have, which I believe started before the pandemic, and wanting to know, because in my constituents, most of the people that I meet usually say, I can't be bothered. And in my constituents, when we look at it, people, they have healthy challenges, it's a deprived area, and digital problems are not because they don't have the phones, but they can't afford most of the things. So phoning the doctor at 8 o'clock, and it's quite a challenging thing because they find it very difficult, they can't get through. And then the next thing, they can't be bothered anymore. And by the time they present themselves to the either Royal Berkshire or to their GP, that prevention hasn't happened at all. So I would like to know more if the report is going to look at things, how you're going to take forward the 8 a.m. rule that everybody seems to struggle with, especially I've looked at most of the people in my ward have complained about that. Thank you.
I'll start off, Andy, if that's okay. I think there's a bit of misnomer as such in the fact that actually everybody's got to phone up their GP at 8 a.m. when actually the doors open. Actually, GP practices are open, like Andy's practice was open until 7 o'clock tonight, wasn't it, Andy?
My last patient was at 6:15. I just finished at 6:30.
6:15, but lots of practices actually open up even longer than that. Some practices are open up to 8 o'clock in the evening. I think we've got to change the overarching population's belief in the fact that actually you have to call up your GP at 8 a.m. in the morning. Most GP practices do get an influx of call first thing in the morning, and that does put a pressure on the overarching GP practice. But all GP practices are open all day, and actually they can call up, they can actually say their issues. That is individually triaged. There is a callback, and actually they would actually hope to get a call back on that day. Obviously, it's, if they call up at 6 o'clock at night, obviously the individual GP will actually, if there's a risk sign, a red flag sign, they will call back. But if it felt they could wait until the next day, then they will call them back. So is there a role, I think, for Reading councillors and the members here to try and actually get your individual constituents to take a slightly different approach instead of the old model, which was back in the 1980s and 90s, where actually you needed to actually phone up your GP to get an appointment on that day at 8 a.m. Could we actually get some communication out to say you can call your GP any time of the day? We could actually share with you the individual practice opening hours. You could actually put that across and actually say they can phone up at any point of the day and hopefully get a call back. Is that a better way of actually providing that support, councillor as such. What was your thoughts there?
I think the rule specifically means if you want to get an appointment on the same day, you have to phone at 8 o'clock. If you phone maybe 10 o'clock, they'll say phone tomorrow, or even if you want a doctor to call you. I'm definitely sure about that. I've helped a few residents do that. I've done it myself. If I miss the slot between 8 and 9, they'll say, if you want an appointment on that same day, it is the rule that comes from the GPs, not from the local council or anyway. So I think the message has to come from the GPs to say that even if you call at 11, you can leave a message or whatever the doctor to call. But then when you pick up the phone at 11 and you can't get an appointment on the same day, they'll have to ask you to call at 8 o'clock again the next day. That's what happens.
Andy, do you want to come in?
Well, when I started in my practice, we used to open the doors at 7:30 in the morning. There'd be a queue outside for what we called the quickie surgery at the time, which was all the on-the-day urgent patients would come first thing in the morning and queue up and then fill the surgery, and then they'd be seen in very quickly first thing in the morning before we got into the routine days working. When that queue started stretching around the corner and we were busy doing on-the-day appointments till about 11 o'clock in the morning, we realised we had to make a change, which is why we then started a triage process for patients who wanted to be seen urgently on the day, and we had to readjust that. I mean, it's a real challenge for general practice. I must admit, you know, however brilliant my practice is and the processes we have, there are challenges across all of primary care in different practices, depending on their model of staffing, who they've got available, how they've done things historically, how their patients behave. There is no one rule to how we do things. And yes, I probably concur with the councillor that there are some practices who maybe still work on an 8 o'clock rule, that, you know, we only have so many appointments available during the day. Once they're full, they're full. So obviously there's a scramble at 8 o'clock to get those appointments. If you work in a system where actually you spread your workload out through the day with who's available to deal with patients, you know, patients get used to that idea, and then they know they don't have to scramble at 8 o'clock in the morning, because they know if they ring at 10 o'clock, 11 o'clock, or even first thing in the afternoon, if it's an urgent problem in the afternoon, they'll get a call back and they'll be seen that afternoon. Different practices run different models, so I can't give that there's one hard and fast answer to the question about the 8 o'clock. There may still be practices and do that. Mine doesn't. Yes, we do have a flurry 8 o'clock in the morning, but our practices and our practice patients are maybe not trained, that'd be the wrong word, but have got used to what the offer is we've got, and know that we're available all day, and they know if they ring at 6:15, a doctor will answer them. And I've answered calls at 6:30, or if they've rung at 27 minutes past 6, I'll be still ringing them at 7 o'clock or whatever time I can get to them to deal with them. You know, we don't shut shop and not ignore patients. You know, we deal with them until our work is done. I'll still be doing paperwork after this call because I had to finish my surgery and I haven't finished my day's work yet. So yeah, we can have that conversation between primary care and patients and the perceptions that people have, and we can go to our practices and find out if they run an 8 o'clock rule, but I would suggest that probably a majority of our practices don't. And where it still happens, maybe there's a little bit of peer pressure and looking at how we can improve the way they operate, and share some good practice from other practices. But like I say, we are individual practices. We can't tell people how to do things. It's maybe through patient participation groups and talking to your own practice that you can make suggestions. This is the experience we've had. Can you make a difference? And that's how we've learned over the years. We've listened to our patients and we've tried to adapt what we do. I hope that helps.
What we can do is actually, Sanjay, as the interim head of primary care, we could do a little survey to ask about what the current practices are. And as Andy was saying, peer-to-peer conversations is a very powerful influencer. So we can actually bring this up at a call between the Reading practices and actually use it as best practice models. But as Andy was saying, leveraging that PPG or patient participation group, their patient participation groups is a really good way of going forward. So I would support Andy in that conversation about doing that peer-to-peer conversation.
Oh, thank you very much.
Thank you for that. So I've got one final comment on this item, and I thank you three for your time, bearing in mind it's getting late. So Councillor Hoskin.
Yeah, very briefly. So yeah, thanks for that. I think the conversation has demonstrated the need for this piece of scrutiny around same-day access, and certainly, I mean, I have exactly the same experiences as you do, and I think, you know, there is something about the reality on the ground as opposed to kind of what we kind of hope through the policies, and I think perhaps the unintended consequences of the system is something that needs to be explored, such as because there's certain, you know, only a certain amount of access, everyone trying to get in their 8 o'clock. And I think that's very much a more common experience than perhaps you might imagine. And there's certainly something around best practice, and it is challenging and frustrating that that these practices are independent organisations that can do things their own way rather than, you know, so there is something about networking, there's something about best practice, but absolutely I can see, you know, this, I think there's more to be looked at, and a scrutiny of this and how this is connected right across the piece, I think is really important, because it's not just about a walk-in centre, it's about how people get medical advice and support that works for them and is best for people's health and well-being in the round. So yeah, I think I look forward to that, and I do wonder whether we might just need a slightly out of cycle informal meeting to get some of these things aired, so that when we go to the actual scrutiny element, we've kind of like got that out of the way. I don't know if that's an idea as well, Chair.
I think that certainly is. Okay, thank you. That was, I think, a more exciting debate than we're sometimes used to. So, Katie, Sanjay and Andy, thank you very much for your time. And as we said before, we much appreciate your hard work. Colleagues, I'm going to adjourn actually for 5 minutes. So I'm going to give everyone the chance to move around, and we'll be back at 7:57. So thank you very much for your assistance this evening. Thank you.
Great wave.
Thanks very much, Chair.
Great, thank you.
Yep, let's go. Welcome back. Okay, so the next item on the agenda is item 8, which is the One Reading Children and Young People's Partnership. So, Deborah Glassbrook, I believe you're presenting.
Yes, good evening, everybody. We've actually got a presentation from our colleague Kirsten Carr, who's going to lead us through this presentation, if that's okay. Thank you very much.
That would be lovely. Welcome, Kirsten.
Thank you. Thank you, Chair. So I'm just going to check. Can you see the slides?
Yes.
We can.
Good, lovely. Since we presented the strategy probably about a year ago to you, we've established partnership work streams to progress collaborative working in the 3 priority areas of our strategy. So for under 5s, young people, and emotional wellbeing and mental health. So I'm just going to talk you through some of the progress and updates of those 3 areas. Our under 5s work stream agreed to be the delivery group for Reading for the health and wellbeing strategy priority 3, which is the under 5s. And that work stream's developed a single action plan to avoid duplication that's now in draft format and is currently with stakeholders for feedback. The group's also working with the LGA, with the Local Government Association, to develop a partnership under 5 strategy, which should be complete in May. And partners have successfully secured funding for a 5-year programme to upskill the workforce in identifying and working with children with SEND, with special educational needs and disabilities. We're also currently waiting for guidance on changes to how the foundation stage is assessed. So that assesses the children's readiness for school. And due to the review, there's been no annual assessment for the last 2 years. And that means that it's quite difficult to know the impact of COVID because we haven't had the data to benchline as it was disapplied. So children who would have been in a setting, who weren't able to access a setting, are now entering our settings. But practitioners have been grappling with understanding whether the needs that they're seeing, so anecdotally settings are telling us that children are arriving behind what expectations would be. And practitioners are grappling with understanding whether the needs they're seeing are related to environmental impact or whether they're related to special educational needs. And that really sets the context for some of the key actions of the group. So one of the key action priorities is increasing the number of 2-year-olds accessing nursery places. And there's been progress on a term-on-term basis, and we now have reached 74% attending a setting. One of the things that's been really successful in achieving that is the setting up of the new Parents Champion scheme, which means that a group of parents are able to talk to other parents about take up and encouraging that take up, and that's working really well. Another key area has been working on speech, language and communication. That was in an area where there was underperformance. So a multi-agency working group's been established to develop a network that's had a really strong focus on promoting the Every Communication Matters approach and earlier intervention. One of the key areas of concern that we had during the pandemic and the early stages of the pandemic was the increase that we saw in non-accidental injuries for unborn and newborn babies. So we reviewed the multi-agency pathway and now have maternity, health visiting and children's centres meeting on a fortnight on a regular basis to identify families that they think would benefit from early help at that earliest opportunity. And we also have an infant coordinator that's working across settings in the community. So one of the things that we're very relieved about is that we have seen a reduction in the use of the bruised baby protocol since the spike that we saw in the pandemic. Just moving on to young people, the adolescent risk strategic groups, a subgroup of One Reading, and that has the role of driving and overseeing the priorities that relate to young people within the strategy. A key priority for that group has been to develop a partnership extrafamilial harm strategy. So by that we mean harm that takes place outside the family, so the harms and complex issues that young people are faced with their peers, in schools, in community and neighbourhood settings, and in the digital world. So the strategy outlines really how we'll work collaboratively across the partnership to prevent and respond to child sexual and child criminal exploitation, missing children, gangs and youth violence. So we held a series of workshops over the spring and the summer with partners to develop and inform the strategy. We looked at our local profile, what we know about the young people who are at risk. We looked at national research and our understanding of what works nationally as well as locally to inform the strategy. And that led us to the priority areas within the strategy, and we now have a clear action plan to implement that strategy. And there's a strong emphasis there on early intervention and prevention, work with schools, collaborative work with young people in the communities to jointly raise awareness, identify concerns and working together to identify solutions. But there's also a strong emphasis on disruption and enforcement activity, particularly targeting adults who coerce and groom some of our children into criminal activity. So as I said, the action plan's now in place. It's incorporated within the wider serious violence, or will be incorporated within the serious violence strategy plan and the community safety plan. And it's been signed off by the One Reading Board and the Community Safety Partnership. And linked to this priority really is the development of the youth offer, which was identified as a priority for the group, building on the recommendations from young people's research through the Growing Up in Reading research and the other pieces of research that have been taking place over the last year with young people. So we've been working with voluntary community sector organisations with RBA to undertake a mapping and needs analysis to inform where the gaps are in Reading and to inform future joint funding bids and so forth. So I've probably talked about most of the actions that group's focused on, but just to add a few more or in a bit more detail, the action plan's now in place. That will be monitored by the Adolescent Risk Strategic Group. A subgroup's been established that's being led by one of the youth organisations, working with youth organisations who are working with young people with lived experience to develop a young people's version of the strategy, but also to ensure that there's continuous co-production and working with the young people on the plan going forward. The last year, reconfigured some of our youth services within Brighter Futures for Children, some of our services, to establish a new Reconnect team that's specifically focused on working with young people and their families where there's a risk of extrafamilial harm. There are also a number of other partnership projects where we're wanting to understand the impact and seek sustainability. One of the examples of that being the Violence Reduction Unit funded Hospital Navigators programme that started this year. Starting Point, a voluntary sector organisation, are leading on that, coordinating groups of volunteers to support young people when they present at A&E, supporting young people to access early help. And there are some good early outcomes from that piece of work. I've talked about the youth offer, so I'll just move on to the third work stream, which is really focused on a consistent approach to emotional well-being and mental health, and it's particularly focused on embedding trauma-informed approaches across Reading and to our emotional well-being and mental health offer, but also making sure that there's a clear and accessible offer to young people in Reading, particularly in that context of that wider work within Berkshire West and the work that's developed on that wider geographical footprint. The other concern for that group has been the impact of COVID and the spike that we've seen and the concerns for young people in terms of their mental health. So the priorities for that group have been to set up a network, establish a trauma-informed network across Reading, which a number of voluntary organisations and services across Reading are attending to share knowledge and skills and developments in embedding trauma-informed approaches across Reading. And that includes the schools network that's now established with the Therapeutic Thinking Schools programme. One of the responses to the level of need that we're seeing in Reading in terms of young people accessing emotional wellbeing, mental health support is the development of online support for young people 24/7 service through COOTH, and we're seeing the highest number locally of young people accessing that service are from Reading, so it is being well used. Very briefly, some more general updates around early help. We've got the national launch of Family Hubs, which is a programme focused on universal co-located and virtual early help offer. There's a funding stream that you may be aware of linked to that development of 82 million, and plus there is further funding, national funding for parenting programmes and the Start for Life offer that are linked to the development of Family Hubs. So we have started to have some very early discussions with partners at the One Reading board about potentially or exploring the feasibility of developing a family hub model in Reading and establishing whether there's partnership appetite to do that. There's also, we've had the confirmation of the 3-year continuation of the Supporting Families programme, which was formerly the Troubled Families programme, with an increase in numbers and resource nationally, and we're just waiting to hear what the funding allocation will be in Reading. And we've been using some of that Supporting Families programme in the last year to establish partnership outreach workers who are establishing forums and surgeries in schools and in the community to support partners to develop early help plans and responses to families out in the community. So that's quite a quick whistle-stop tour of the developments in terms of the early help strategy in the last year. I'll just finish there.
Thank you very much. Over to you, Councillor Terry.
Well, I wasn't planning on saying very much, really. It is an update report, and I think it would be give the time to other members of the committee to ask questions.
Okay, any questions? Councillor Shikali.
Hi, thank you for your presentation. I have a couple of questions. Some of them might not be real questions, they might be just points of clarity. But my first question is on priority 3, reduction in non-accidental injuries suffered by unborn and newborn babies. One of the metrics is the increase in referrals. Is it, as a result of the increase in referrals, is a way of my question is it a way of actually having access to people who have more potential to harm their babies that's reducing the use of the safeguarding protocols? Is that actually the link? I'm trying to understand the mechanism there.
Yes, so there would be an expectation that if there is a concern about bruising, non-accidental injuries, then that protocol would be implemented. So a reduction in the use of that protocol is a good sign in terms of it not needing to be used.
But this is caused by the increase in referrals, so people who might be needing that additional support not to get to that point. Is that right? I'm trying to understand that best.
Sorry, I'm not quite understanding.
So I'll say that again. So it says increase in referrals to children's centres for first-time parents. So is it that resource, that additional support, that's actually driving down those numbers?
So it's very difficult correlate, but we would hope that the partnership response and having that, having increasing numbers accessing children's centres at an earlier stage, having that early pathway so that maternity, children's centres and health visitors are having those conversations on a fortnightly basis so that they can raise concerns about families early and get that early help support in. We would hope that that would have an impact on those figures.
Thank you. So it's more of an integrated, holistic approach that's resulting in that change. Well, fantastic work. Just a couple other questions. On priority 1, ensuring effective partnership prevention and response to extrafamilial harm, you've got the pilot project to prevent school exclusion. How does that work? And does that target people more at risk of being excluded from school, like certain demographics or socioeconomics or something like that? Is that included in part of your pilot project? I'd like to know more about it, if that's all right.
Can you ask all the questions at once, please?
Okay, that's the one question. Okay, my last question. So you've talked about the parent workshop pilot under the consistent approach to emotional wellbeing and mental health update. How does that work? That's my other question. And then my final question is, you've talked about the accessible, trauma-informed mental health resource that's now online support for young children. Is this something that we can kind of signpost all our young people in Reading to access by themselves, or do they need a referral or some other way of accessing this? My final question. Thank you, Chair. I know it's a long list.
No, that's fine. Thank you. So the first question, I think, was about the schools pilot project. So there've been a couple of projects, but the key project that we were referring to here is a project that's being funded through youth offending prevention funding, and it's working with a school to provide family support and youth support in the school so that when a young person is on the brink of being excluded, whether that's for a fixed term exclusion, well, particularly out of fixed term exclusion, so at that early point, we would be able to offer a rapid response to that, and a restorative approach to preventing that young person and that family, to prevent that young person from being excluded. But it's part of a wider piece of work to do some work with the school in terms of thinking about more restorative approaches as a whole school approach in order to prevent exclusion. So although there's some targeted work, if you like, with individual young people at the point of exclusion to try and prevent them from being excluded, we're hoping that what we'll do through that project is develops a different way of working and different relationships between the young people, the family and the school, so that we would see a change and a reduction, a longer term reduction in exclusions. That project's at a very early stage, it has to be said, so it's too early to report on outcomes from that project. But what we'd be hoping is if there's some learning from that, we could share that then with other schools.
You can continue on with the
second point was the parent workshops pilot. And I think that piece of work came about through our education psychologists and primary mental health workers were working together to offer a programme that was focused on supporting parents with children's worries and anxiety. And when we went into the pandemic, that had been a sort of face-to-face group work programme. When we went into the pandemic, they started trialling one-off workshops instead. So they condensed that programme into a series of one-off workshops that are being delivered via schools, sort of on request by schools, that parents can attend. And the third one was, I think, about the online support for young people. And that's via Kooth, which is a website that any young person could access at any time. And it offers tips, advice, information, and also somebody that a young person can speak to 24/7.
Lovely. Thank you. That's quite a chunky one. Councillor Robinson.
Thank you, Chair. You'll be delighted to know I'm not actually going to be asking any questions. So you're getting off lightly, Kirsten. I just wanted to say thank you for giving us the update. I'm sure we're all aware that early help, early intervention is a vital component of children's services. The ability to provide needed support and assistance to children, to their families, and also to the youth as well, is vital. And you know, certainly it's great, and it was great to read the report. The amount of progress against the priorities, I think, is fantastic, especially against the backdrop of the difficult year that we've just come from. So my congratulations and my thanks to you and the team for what you do. So thank you.
Thank you. Councillor White, I'll come back to you.
Thank you, Chair, and thank you, Kirsten. I just wanted to ask about the development of youth offer, which was mentioned in the presentation. You had a bullet point on gap analysis that either was being done or has been done, and you talked about you mentioned the recommendations from some of the young people's research. Some of this I've seen has been about providing places for young people. Youth clubs, I'm assuming, would feature in that, and I was just interested in what your thoughts were in that area, if you could expand a little on where you thought that would be going.
So I think what we're consistently hearing from young people is that what's really important to them is having safe places to be within their community, having safe adults that they can talk to. The challenge for us as a partnership is about resource, and one of the things that we've developed in the last year is a strong network of voluntary sector organisations who are working with young people to make sure that we're regularly updating each other on some of the themes that are emerging sort of across Reading for young people, that we're aware of what delivery there is, and so we're making best use of the resources that are out there. Another piece of work has been that sort of within Brighter Futures has been to look at how youth support workers are working at the moment within Brighter Futures. So there's been a strong focus in the last few years on delivering one-to-one work, and that is being requested. It is being asked for, it is in demand, but we're looking creatively at how we can begin to release a bit of resource to enable our youth workers to have a more visible presence within their communities again. And we have got some continuation of HRA, housing revenue allocations grant to support some detached youth work in Reading, and we've got that, I think, secured for the next 2 years. There's that, so that's some of the developments linked to the youth offer. I think young people have told us very much that they want a diverse youth offer, so an offer that responds to the diversity of young people in Reading, and that one of the things from the Growing Up in Reading research found that young people from Black and minority communities are less likely to be accessing positive activities in their community than white young people. So they were felt very strongly that the offer needs to be more inclusive going forward.
Thank you. Okay, no further indications. So, Councillor Terry, would you like to wrap up?
Yeah, Thank you, Chair, for letting me come back. I just wanted to make a couple of points, and thank you, Councillor Robertson, as ever, for your fulsome support for the work that goes on in children's services, and I'll echo that. I think the thing about the Borough's protocol is that particularly early on in lockdown, I suspect what we think probably is that there were more new mums being very isolated and finding it very difficult to cope without the support networks that they would normally have. And so bruising and non-accidental injuries were something that we were seeing. What I'm hoping is that as over time we've opened up to some extent, and we've been able to do online support and other things that have been happening with health colleagues, is that those new mums have been getting better support, and I hope that that is helping them to cope and manage, because having a new baby, particularly if you're on your own and you're isolated and you can't go out and the child is crying and or maybe not feeding well or whatever it might be, those of us who have been mothers and those who haven't, I'm sure you can imagine, it's very stressful and it's very difficult if you can't reach out and have somebody who you can say, please watch the child, I need to break and I need to go away for a minute and come back. So that I think we're hoping that that's what happened, and it will get better. But it does serve as a reminder of the support that certainly new parents, not just mums, need in those very early days. I wanted to make a general comment about family hubs. The government has made this announcement about funding for family hubs. It sounds like a lot of money, but it's actually sort of £1 million to each area. So there's not as many areas as you might think. The bidding process and the criteria isn't really always clear, and it looks difficult, and you have to do it in partnership, and everybody has to sign up, and everybody's really running around doing lots of other things. So although we've had the workshop and there is absolute commitment to people that they would like to see Shaw start 2.1, because really that's what it is, or 2.0, whatever. That is a very difficult thing for us to be able to manage at this time, and putting a lot of effort into something that there's no guarantee you'll be successful. And that would be just sort of like a money to get started. We wouldn't see these family hubs for some time. So I'm not saying we're not interested. I'm just flagging up to this committee that, it may come to not very much, because it looks like it's going to be very tough. I suspect it'll be wrapped into levelling up, whatever that is, because nobody's seeing it elsewhere in the country, but if it is, it's probably levelling up money that we might not get to see. I think the extra familiar harm strategy is something that it's been signed off on one level, but the action plans are still being put together. And I will say to Kirsten, to the colleagues from Brighter Futures for Children, we know that it does seem to be, particular cohorts of our young people that seem to be in this group, and we need to understand that, and we have agreed to do some further work, and I'm sure that we will bring that back to committee at some point, but it's something that needs a lot more thinking and searching about. And also just to say that when young people get into harm outside of their families, the actual law that children's social care works in is about families, it's about supporting them, it's about protecting the families. There isn't actually a statutory sort of framework to work in around this. It doesn't exist in the same way. So whilst it is still about protection, and that's what we're all about, it's actually quite a different, it's quite different. It's quite a new thing in a way, to the extent that we see this going on with county lines and other things. And nationally, we need to be coming up with a different approach in terms of our social work, if you like, in relation to this, and how we can support families and these young people who find themselves perhaps vulnerable and drawn into things that perhaps they don't understand the consequences, and before they know it, they have a criminal record, or they've been seriously harmed and abused, and we need to work through that. I think just finally on the youth offer issue, we all know that across the country, youth services was disinvested in because of austerity. And we all know we want to reinvest in it, because it is one of those key, pillars, planks, whatever word you want to use, of ensuring that young people have, receive the support they need when they need it, and socialise in good ways, etc., etc. And we do need to find some more money to do that, but it's just not available at the moment, and not during a COVID, and not during this crisis have we been able to find the right space and the right time to do that. But our voluntary sector partners, who do run a lot of the youth provision in the town, are really keen to work as a sector as well, to look at how they can bring more resources in. And I know that Brighter Futures for Children and the council will do all it can. We're really grateful for the colleagues in the housing service who recognise the importance of supporting through the housing revenue account some of this work, and we'll continue to look at that. But we really need to call on the government to start recognising that You know, what is happening every week, we hear, particularly in our bigger cities, you know, but also here in our own town, is young people, particularly young men, particularly young black men, who are getting involved in situations where knives are coming out and people are dying, and that can't be sustainable. That's the end result of not being able to divert young people into more productive ways of spending their time, to keep them away from people who groom them, to keep them away from people who will take them down this path. And until we do something about it, this will continue to be a significant problem for this country, and it needs addressing, and we need a government that will address it, and I'm sure the next Labour government will do that.
Thank you. No further comments. That is the end of the item. Are the committee happy to accept the report, please? Thank you. Item 9 is the Children's Social Care Complaints Report.
Good evening, Chair. Can you hear me?
Yes, we can hear you.
Thank you. I'm going to present the Brighter Futures Annual Complaints and Compliments Report first. My name is Nina George and I'm the Customer Relations and Information Governance Manager. All read the report, but I'll just quickly go through and highlight. I'm just conscious of your time as well. This report is to provide an overview of the complaints and compliments activity, performance period 2020, 1st of April 2020 to 31st of March 21. We recognise that complaints are an important part of information to help the company understand where and why changes need to be made to improve the service provided. During this period, the company received 70 statutory complaints, which is a decrease of 23% compared to the previous year. 13 of these were resolved through what we call ADR, alternate dispute resolution, and that's mainly by the social care teams at the first point of contact. The remaining 57 were investigated as formal complaints through different stages of the complaints procedure. Sorry, at stage 1 of the complaints procedure, although 3 of these were subsequently withdrawn by the complainant once the investigation had already started. During this period, we had 11 complaints that progressed to stage 2, and one of these stage 2 complaints progressed to stage 3 as well. Just to give you some context, this represents 2.9% of the referrals that were taken. So 2,384 children were referred to children's social care in that period. We had 68 complaints that were logged for Brighter Futures, compliments as well, that was logged for Brighter Futures in that period. The Appendix A of the report provides an analysis of the data for statutory complaints, and it also explains how the complaints are managed and how the learning is used to improve services. We have seen a 22% decrease in the number of complaints received compared to the previous year. And of those, sorry, I didn't want to repeat myself. Of the 54 that were investigated, 28% were responded to within timescale, with the remaining 72% going over timescale. I just want to clarify that the service was suspended last year because the customer relations functions and the staff within the team were deployed to other services due to the pandemic. So the service was suspended between March and June 2020. The customers were informed, but we did record these as being overdue. All of the complaints that were open at the time and any received were dealt with by the end of July 2020. And just to say that the Ombudsman also followed the same principles and process, so we took that from them, and the staff provided a valuable service elsewhere at the time to support the pandemic. Of the 54 complaints that were investigated to an outcome, we had 14.8% of them that were fully upheld. 25.9% that were partially upheld and 29.6% that were not upheld. There were some others, which is reflected in the report, where how they were recorded differently, so no outcome, and we had a few that had multiple outcomes. In terms of the complaints that went to the local government and social care ombudsman between that period, there were 5 representations from dissatisfied service users, and this is the same as that was in the previous year, where we had 5. And of the 5 cases, the ombudsman investigated 2. 1 was upheld and 1 was not. The other case had either progressed through, had not progressed through the complaints procedure, or it was deemed not within the ombudsman's jurisdiction to investigate. They were seen as premature, and the ombudsman didn't issue any formal reports in that financial year for Brighter Futures. So that's just a brief outline, and I'm happy to take questions.
Many thanks, Nyana, for presenting that. Councillor Terry, did you have any comments first?
I have nothing to add to the introduction. See if those other colleagues have questions.
Okay. Councillor Mpofu-Coles.
Thank you very much. Thank you, Chair. I just wanted to go to page 32, which talks about training is now available online. Also, this can be accessed by all social care staff through BFCC's training department. Take up of this online training has been very low. How can you relate that to what has been happening with the staffing and the complaints and the training? Can you interlink those together?
So, sorry, are you asking me or?
Yes, about the complaints and the staffing, and we go on the fact that you did some training, but the online training didn't have a high intake, and then the face-to-face one, did it seem to have more intake, and how has it been balanced? Because we know that there's a lot of problems that has happened because of staffing due to COVID.
Yes, so in the last financial year, although I appreciate that the online uptake was low, we ran a number of face-to-face sessions for staff, and they were fully attended and well attended.
Okay.
So, yeah.
Yeah, thank you.
Thank you very much. Councillor Robinson.
Thank you, Chair. I love this report every year because it just gets better for me year on year, seeing the complaints not only being reduced, but also the detail and for me, the comprehensiveness of this report is great. And I love the idea that once a complaint has been received and it's been dealt with, it's not stuck in a filing cabinet somewhere. You actually take the learning and you actually build an improvement into the process based on the back of that. So, my thanks again for all the hard work and effort that you put into the report and your presentation this evening. And again, I always end off by looking at the compliments received. And I would strongly urge, if you haven't had a look at the examples shown, it's a great news story that we do get such comments made by members of the public and by those that have been touched by the service provided by Brighter Futures. So thank you again. Okay.
Thank you, Councillor. Thank you, Councillor Robinson. I think there are some invitations there. Councillor Shikale.
Thank you, Chair. Honestly, you're welcome over here. You're well loved. Honestly, wanting to thank them as well for actually 68 compliments this year. It's amazing and a very hard year, and a reduction in complaints and the handling of it very well, as discussed by Councillor Robinson on the other side. But honestly, fantastic work, and keep it up. It's incredible, especially with, restrained resources as you've had. Thank you.
Thank you. Okay, committee, are we happy to accept the recommendations for the report? Okay, so thank you, Nyana, for that. I believe you're presenting the next item as well, aren't you? Okay, let's roll straight in. Thanks, everyone.
Thank you. So the next item is the DAX Adult Social Care Report. And again, this provides you with an overview of complaints received in the Directorate between April 20 and March 21. So during this period, the service received 17 what we call corporate complaints. It does demonstrate a 30.8% increase compared to the previous year. However, the statutory complaints that came in, we received 71 and we've seen a 15.5% decrease to the previous year. I'll just touch on some data for the corporate complaints. We had 7 upheld, 1 part upheld, 4 not upheld, and no outcome on 2 and multiple outcomes on 3. Sales were 47.1% was in timescale, 52.9% was not in timescale. For statutory complaints, like I said, we had a decrease of 15.5% compared to the previous year. We had 26.3% upheld, 5% partially upheld, and 36.8% not upheld, and a number with various outcomes. The timescales there are, we had 47.4% in timescale and 52.6% which went over timescales. And I won't repeat what I said earlier because we're all part of one service. The customer relations team manage the complaints for the whole of the council and Brighter Futures. So when the service was suspended, the timescales were impacted. But to stress that everything was dealt with by the end of July and customers weren't kept waiting unnecessarily.
Thank you very much.
Oh,
my
sorry.
Apologies. Continue. Sorry, I thought you'd finish.
With regards to ombudsman cases for DAX, again, we had 5 representations relating to the service. This is slightly less, 2 less than the previous year. And of these 5 cases, 2 were assessed and not investigated, 3 were investigated, and the ombudsman upheld 2 of them and found no fault with the remaining case. Not upheld, and once again we had no formal reports around maladministration by the council, so it's positive, and we recorded 28 compliments for adult social care. I'm still encouraging the service to log more because I'm sure they're getting them, and Shona and I have discussed how we can make it look positive by changing our feedback email address so that staff are encouraged to push that through to us, because we welcome both sides, you know, we want a balance. So thank you.
Thank you very much. Councillor Ennis.
Thank you. Yeah, thanks, Nana, and thank you to the corporate staff for all their hard work in what has been a difficult period. I mean, in fact, we could say in adult social care, this is one of the toughest periods in the history for adult social care, having to focus and prioritise services for the most vulnerable residents who were relying and are relying on our services. And I take the point about the suspension for that period, that most difficult period, if we can cast our minds back. So that may have something to do with the timescales, but I'll come on to that. You know, even then, I think it's good in a public forum for the residents of Reading, if they want to, they could listen to Reading versus Luton. I wouldn't personally, but they could listen in to this and get a public scrutiny of the complaints and the reports of residents' unhappiness with the services in an open forum. And I think, and the results to come out in a comprehensive report in a non-defensive manner. And I think we need to note that. And I think we need more of that because we are a cross-party scrutiny. And when you get members from the opposite parties joining in the scrutiny, it helps. And it helps to make the service more effective. So it's really good that we got these reports and we need to examine them properly to ensure, because the figures might look good in parts and increases, but behind the figures are stories of residents who are unsatisfied, who felt the need to complain and were concerned about the services that they were receiving. I'd like to reassure, we should reassure our residents that we use these reports not just as number crunches, which we can have that risk of, but to actually delve behind the complaints to ensure that we can learn from them and that we can move forward. So we would seek assurances as a lead counsellor for adult social care, would be working with officers to seek assurances that, number one, the timescales are met when we can meet them. Obviously, that period was difficult, but going forward, we should be able to improve the timescale figures, but also to ensure that we learn from the complaints, and that we work to make sure that it's less and less. So I very much welcome the report, very much welcome the details, and thank you very much.
Thank you, Councillor Ennis. Councillor Chocolate.
Thank you, Chair. Once again, congratulations on your work in the pandemic and reduction in your complaints compared to the 2019/20. I have a quick question on the procedure. I know we've talked about it, but I do want to just go into this. So when you've gone through stage 1, stage 2 and stage 3, if a complaint gets to that stage, how do you evaluate afterwards that the complainant is happy with the outcome?
So within adult social care, we only really get one opportunity to respond to the customer because the regulations changed in 2009. So we do a very thorough investigation report, and that's then signed off by either Shona herself or one of the assistant directors. And the complainant then has 20 working days to review that and come back to us to have a further conversation if they're not happy. And so if they do that, we meet with them. So myself and one of the assistant directors would meet with them along with the investigating officer and try and come to a resolution. And usually we do get there, but you will always have a number of customers who will go further and go towards the ombudsman. So they have an opportunity a time period to feed back to us.
Thank you. Right. I think we're going to move on because of time. Shona, I don't know if you had any comments.
I guess just one comment, Chair. I mean, obviously we try to minimise the number of complaints that progress because it's much better to resolve them at nearest to the point of service as possible. And that's what we're striving to do, is so that, the Ombudsman isn't troubled, that actually we do kind of deal with it at the lowest possible point, because it's better for the person and it's better for everybody involved and for the person receiving the service if we can resolve that. And hopefully next year you'll see a change in the timescales, because we've worked really hard in order to do that, because it's in everybody's interest to respond fast. And I think Nyana can say to you that hopefully next year the report will show a significant improvement.
Yes, just to add, the data we've had in the last quarter 2 of the financial year has shown some improvement. So, and that's the way that we want to move things along.
Thank you. Councillor Ennis.
Yeah, thanks very much. I just want to make one point, is don't forget the compliments, and there were numerous compliments, many compliments, which to me seemed authentic and genuine. So we mustn't forget that when we're examining and scrutinising this report. Thank you. Thank you,
and thank you, Nyana, for your time tonight. I realise it's getting late in the evening, so we'll let you get a hot chocolate and get off to bed, I think. Okay, committee, are we happy to accept the recommendations? Lovely. Okay, on to adult social care reform. Shona Douglas.
Yes, thank you, Chair. So this is really a paper to note, because I just thought that it would be helpful for members to just be kept up to speed with the adult social care reforms, which I know that you all have heard a great amount in the media about. And so I just thought it would be helpful just to draw your attention to the document, which is called People at the Heart of Care, Adult Social Care Reform. I'm just really wanting to flag three elements here, really. It is a complicated web to navigate, and a lot of the guidance we haven't got, so I can't inform you, but I'll be bringing that as it gets revealed at later stages. But the three areas really to focus on is that people at the heart of care, adult social care reform, talks about the services to be extended around choice and promoting independence and integration with health. And I guess I would want to flag that, you know, I suppose part of the thing I'm really proud of in adult social care is that staff have worked really hard in terms of that independent agenda and ensuring that we keep people at home wherever we possibly can, and where people are in hospital we have a home first principle, and that's embedded in our adult social care ethos. And the work of our hub at the front door demonstrates the number of people where we're kind of really driving that agenda around keeping people at home and out of statutory services where we can. And next, ACU will have the performance reports, which will demonstrate some of the data that supports that. So I think that in terms of the paper and what it's related to in terms of promoting technology care, extra care housing, links with housing, those sorts of things, direct payments, all of those things we're embedded in continuing to develop and move forward on through our transformation agenda. There is an integration paper which we're expecting any moment now, which is the health element of people at the heart of our care, adult social care reform. But we're thinking that will say a lot of the same issues around integration. And we know from the 1st of April, we know it's been slightly delayed, that we're going into an integrated care partnership across what's called the Bob footprint, which you've heard tonight is Buckinghamshire, Oxfordshire and West Berkshire, and so we know that there's further integration work to ensure that Reading gets its place within that footprint. The other two elements are the cap on care, and that's around the amount of contribution that people will pay before the council will pick up the care. And we don't know the detail of that, but we do know that we will get some tools to assess how much that is likely to cost Reading in the future. And we know that along with other councils, there is a concern that we receive the right amount of income in order to meet those needs, because it will mean that people who are self-funders, once they've reached the upper cap limit, that the council will be picking up the cost of their care, so that may be fairly significant. The other element is around the fair cost of care, and again further work, we don't know what that's done, we just know that it's there, but it's around ensuring a decent wage for carers. And of course in Reading we pay the foundation living wage, which we have done and been committed to for many years. So it's around ensuring that we're getting a fair rate of care and that people are paid appropriately for their care, and we're hopefully getting some grant funding which will support some of that. So they're the three elements to the bill. I guess that there's a lot of detail in it. It's probably trying to keep it very focused, that they're the 3 points, but really happy if I can answer any questions if I can. If I can't answer them, I will tell you, and hopefully it just provides you with that note to keep you up to speed with the developments as we move forward with the legislation.
Thank you very much. Councillor Annis.
Yeah, thank you. I think it's a really good paper to come to the council, to come to waste tonight. Much trumpeting going on from government on this, but really and truthfully, we have to be honest with ourselves and say it's more questions than answers. The 10-year vision and the white paper, or the talks of a number of things that haven't really happened. You've got the promise of cross-party consensus on it, which hasn't happened. It hasn't even got off the ground. The creation of a 10-year vision where we don't really know what's coming out of it. The national insurance tax increase, which will hit those on lower incomes the most. It is a working people's tax. And as we speak, the potential for it to be reversed, I think, is more than 50-50 or potential. So that would put the whole situation back up in the air again. The 5.4 billion pounds raised, there's really no plans for it, but we have to be honest. and say that the way the NHS is pressures at this moment in time with COVID and with the winter, which is always a pressure, and also the backlog of operations, will probably take that 5.4 billion plus another 5.4 billion plus another set of money, we have to be honest, because of the pressures that they're facing. And that leaves the question about potentially will 1.7 billion come to adult social care? And if it did, it's a small number given the financial pressures. I think Wokingham have gone public, many councils, Conservative and Labour, and we're talking local authorities here, not necessarily political parties, because there are Conservative, Lib Dem. I don't think there is a Green council, I'm sure there is, but you'll have to remind me, I think it's Brighton. Brighton, absolutely, have come forward and said that there are massive pressures, and we're facing that ourselves in Reading, with COVID and with the pressures on making sure our vulnerable residents are getting the services they want. I'm really heartened to hear. I think we should concentrate as much on the approach to be taken by Reading, because as we're the administration, but also we're the scrutiny members. I welcome that, because we have massive pressures, has been identified throughout the policy committee, on the amount of money that we're spending to ensure that we support those that need it most. And we were working to make sure that case. We're hoping that this does come good. It's not politically in our interest, party politics. We want this to work. We need it to work. The question is whether it will work. And I welcome the response and the approach taken by the Reading Borough Council, and welcome the officers and thank the officers for the absolute sterling work they've done over this past period, where they were able to come in on budget for a number of years, and this period has been the most difficult. And I have every confidence in what we're doing in Reading will help. Very much welcome the fair rate of care, and I'm meeting tomorrow, and we're looking at that, because care workers are asking us what we can do to ensure that they get a decent rate. We've always paid a good living wage in this town. It's what we're proud of, but sometimes that doesn't go far enough for many. So I very much welcome that. And we will work within our budgets to ensure that we will protect and support those that need it most. That's exactly what we're here for, and that's exactly what we intend to do, despite whether or not we get a national white paper on adult social care. Thank you.
Thank you, Councillor Ennis. Councillor Hoskin.
Yeah, very briefly, just to agree with what Councillor Ennis just said. It is disappointing, I think, the incoherence of the government's approach to social care, and the white paper very much only looking at one element, part of it, and not addressing funding issues. And of course, we haven't referred to is there is an integration white paper promised. It was promised a little while ago. It's promised soon. It's promised imminently. Although apparently a lot of it's tied up with the Prime Minister's views around this, delaying it. So that may get resolved quite quickly one way or another. But it leaves us in a really difficult position where the role of local authorities and social care within the health and social care sector is up in the air and is not clear, and we're not alone. Councils across the country are increasingly concerned that the move towards ICSs that's been created by the Health and Social Care Act is basically diminishing the role of councils, local authorities, and by definition local people in the planning of local health systems. That's a problem for us, because the way forward is us working with our local health partners. I mean, it's the move towards the Oxfordshire and Berkshire West has been delayed till July due to various issues. So what we can do is to carry on working hard to try to deliver what we can, build those relationships, and have that local working with health service. But it is really difficult. And let's not forget that before the pandemic struck, the NHS would act. I was going to various meetings where, you know, the spending gap was considerable and huge. It was a historic spending squeeze, and that's only exacerbated. So in terms of funding, I'm not sure where that's come from, John, because the NHS is not going to have enough money to survive even with the promised increases. So in terms of that, we have to hope that something does come out of government. Perhaps a new Prime Minister might shift things along. Who knows?
I think some more parties might help us all. But okay, I don't see any further indications. So are we happy to accept the report? That is lovely. Thank you very much. So the next item is the hoarding pilot project. And we're really excited about this one because it's an interesting project. I think Shona Douglas is going to kick us off, and then we've got Joe Lapan and Sarah Martin as well joining. So Shona.
Thanks, Chair. So you'll recall that at the last ACE we presented the Safeguarding Adults annual report, and within that we talked about the hoarding project, and we were asked to come tonight to talk about the project. And so Joe is here, and Sarah will take you through the presentation, which isn't too long, but they'll tell you how long it is so that you know where we are, because we're conscious of time. So thanks, Joe.
Evening, thank you very much for inviting us. It won't be very long. We've got about 5 slides, and then we did have a video, but with the best attempts in the world, we couldn't get it to play. So we'll give you the link for the video, which you could go away and watch if you wanted to. So yeah, just some slides to talk about the Reading Hoarding and Self-Neglect project. The photos are all photos that have been taken by staff in the adult social care team using a hospital discharge grant that is in place to help with delayed discharges from hospital for those people who would have been going back to these properties. So this is a grant that's in place, and it's been in place since about March 20, and the money's used to try and help people clear their homes and get repairs and things done before they can go home from hospital. So starting off, what is hoarding? It's collecting and failing to discard possessions that appear to have little or no use and storing them in a chaotic manner, and becomes a problem when the amount of clutter is interfering with people's daily living. So you're unable to use a bathroom or a kitchen or sleep in your bed, that the clutter is so great you're just absolutely not able to use your home for what it should be used for. It's often associated with other underlying conditions such as mental health needs or mobility problems, and there are often very great challenges around engaging individuals with working towards clearing properties and making properties safe. People with hoarding behaviours are less likely to allow tradespeople into their homes to make repairs, and therefore they may be living in very unsafe properties without access to essential amenities such as water and heating, electricity, all of those things. So that's where these discharge grants are really helpful, because often those services can be put back in using that grant. The next page, thank you. So the aims of the project is about establishing how best to support people with self-neglect or hoarding tendencies, and to ensure that interventions will support longer term needs. I think everybody I've spoken to has talked about it being a long-term piece of work. It's not anything that can be fixed quickly. It's about working with multi-agency partners to provide a collaborative approach, and establishing an integrated pathway to support with those risk management interventions. So lots of people all working together, which, you know, people are already doing, but it's about thinking, this piece of work is about thinking how those pieces of work are being done and how better to join them together. It's about providing training and support to statutory and voluntary agencies on hoarding and self-neglect, and to just generally raise awareness of the impact it has on individuals' well-being. So what have we done? A successful grant application with the total funding requested was secured, and that has allowed for the appointment of a project worker, which is me. I started in October of last year, and I work 2 days a week, so it's still in its early stages. We've already sorted out training, and that's been commissioned from Hoarding Disorders UK, and the first session starts in 2 weeks' time, and then we have a programme of training running all the way through the year. I've been reviewing hoarding pathways and existing services and looking at what agencies are already doing. For example, the fire service with their programme where they'll go in and do a sort of safe and well check. That's probably not the right phrase, but it's what's come to mind. And also looking at all the work that the voluntary sector are doing in this area and in the sort of supportive roles such as befriending people. And we are putting together a hoarding and self-neglect protocol, which we're going to do in collaboration with the safeguarding leads, and that's in its draft form now. Why are we doing it? Hoarding is a serious and significant issue. Between 2 and 5, the estimate is that between 2 and 5 in 100 people experience hoarding behaviours, which, as you can imagine, will have a massive impact on all areas of people's lives, relationships, work. In extreme situations, it can take over somebody's life and can result in fire and falls risks, safeguarding issues, and there are real costs to individuals and also to local services trying to help. Adult social care, environmental health, housing and the voluntary sector have all observed an increase in hoarding behaviours, particularly during the pandemic, and people are much more socially isolated, and that's perhaps been one of the causes for that. And the numbers at the bottom illustrate that between April and June 2020, there were 15.3% safeguarding referrals where hoarding or self-neglect were highlighted as the reason for the safeguarding. They're not separated out at the moment. We can't look at which specifically will be hoarding, but it's a good indicator. And April to June 21, that number's not quite, but almost doubled. Self-neglect is a priority area for the West Berkshire Local Safeguarding Adults Board. And yes, it's a growing issue that really needs to be looked at. So the implications for individuals and for services, obviously for individuals, a poor quality of life and a really significant impact on people's well-being, poor physical health, fear, anxiety, depression, and then for services, the amount of staff time, particularly when something becomes an enforcement action, and just time and costs about cleaning, repairs, and other associated issues such as homelessness. And as I've alluded to earlier on, the delayed discharges from hospital. Often hoarding will first come to light when somebody's being discharged from hospital, and a home visit's made to look at putting equipment or beds and things in, and then it comes to light that the home isn't safe or suitable for that to happen. So our intended outcomes, increased access to services for people, to try and prevent crisis and hospital admissions and try and do some preventative work, enabling people to stay healthy and active in their community and at home. So if people can be helped, looking at those before and after photographs, making a significant difference to somebody's life, and then linking into other forms of support post dealing with the immediate crisis. It's a long-term piece of work, and it's about sort of maintenance as well. And so looking at the statutory and the voluntary services around that can provide that support will certainly be part of this project. Yeah, and with the ultimate aim for individuals to gain greater independence and greater well-being. So that's me. There would have been a video, but you can get the link. It's a good video. It's worth watching.
4 minutes.
13 minutes, Keith's video, but we were going to stop it before 13 minutes. But yeah, it's certainly worth looking.
Thank you very much for that report. I think we can all agree this is an incredibly valuable piece of work. Okay, Councillor Ennis.
It's an excellent piece of work, and it's good to have the presentation tonight. I thought, well, I'm going to have a look at the video when I go back, definitely. I mean, I think the point about multi-agency working is so key because hoarding's got so much issues about vulnerability, mental health, emotional well-being, which will probably go to the heart of why people would want to hoard stuff and keep it. And that's why it's good to have that multi-agency. I used to work with Sarah in a former life, so I've got 120% confidence or more that you're going to do a really good job and bring those experiences of the past, Sarah, into working with people who are some of our most vulnerable, people who need the support the most. So I really do welcome this initiative.
Thank you. Councillor Shikala.
Welcoming this initiative, great to see something coming in place to help people who have been affected and kind of left behind in the pandemic. Fantastic that it's training volunteers, right, and voluntary organisations. Is there a way they get in contact with you? For example, like in my ward, we have the Weller Centre, and they are a really good point of contact with the residents. Can they get in contact with you, get this training to kind of know the signs to watch out for, to be able to support people who might have challenges with hoarding?
Yeah, I mean, the aim is we've got lots of training sessions, so the aim is that it will be open to all sorts of agencies and the voluntary agencies, and it's on my list of doing a check-in with all those agencies to make sure they know about the training and they will be welcome. Yeah.
Thank you very much. Thank you, Chair.
Thank you. Councillor Robinson.
Thank you, Chair. I'm delighted that this is now being put eminently or prominently in the spotlight. I mean, I personally have experience of hoarding from one of my local neighbours who actually, you know, she never realised that there was an issue, but you know, she never threw anything away clothes-wise. And in the bedroom, when I went in there, it was stacked up to the ceiling, clothes from over 50 years. I mean, obviously, it got to the stage where, sadly, because of this, she actually tripped over in the bedroom and broke her hip and had to go to hospital. But in order for her to come home, I had to go in, and it was literally about 50 black bags with all of the clothes that I had to put into a front room. So, you know, it's great that this is actually coming into the spotlight, because I'm sure, you know, that wasn't the only, you know, experience. It's also, I think, you know, an awful lot of research into why people do it, because a lot of them don't realise that, you know, they are causing these issues. So, yeah, happy to welcome this, and thank you for the great work you've done. Thanks.
I just had a quick question, actually, which was just, once the initial kind of cleanup has happened, what types of measures are put in place to make sure that people don't return to that behaviour, and how successful is it?
Well, I've done lots of research. Lots of different areas are doing all sorts of things, working in conjunction with charities, voluntary agencies, or doing different councils of employing people in-house to have a support team so that there's some long ongoing access to help. And again, working within the council, you know, public health, environmental health, housing, all of these teams are having experience of this, and so working together. Yeah. So that's the next bit, really, how the council decides to take this forward, and how we integrate all those different services.
Brilliant, thank you. Okay, I don't see any further indications. Councillor Ennis, did you want to come back? No? Okay, are we happy with the, there's no recommendations, but are we happy with the report we've received this evening? Lovely, thank you very much. Okay, item 13 is the school admissions policy. So, Deborah.
Yes, thank you very much. So I'm going to ask my colleague Jill Dunlop, who's going to lead us on a brief discussion about the school's admissions arrangements that we have prepared for 22-23. Jill, thank you very much.
Good evening, everyone. We're asking that the committee determine the school admissions policies for the academic year 2023-2024. These are the admissions arrangements for community primary schools in the Reading area for that year, the coordinated scheme for primary and junior schools for 2023-2024 school year, the coordinated scheme for secondary schools for 2023-24 school year, the relevant area 23 for 2023 and the map of the primary catchment areas. Obviously these have been sent round to you. It's just to let you know as well that the arrangements for 2023-24 comply with the new school admissions code from September 2021. Reading Borough Council last consulted on the policy in 2018, and therefore there is no duty to consult this year. There have been no significant changes since the 2022-23 policy that came to last year's ACE in July. So we're asking that these policies be determined.
Thank you, Councillor Pearce.
Nothing to add. These are very minor changes.
Brilliant, thank you. Any indications? Councillor Carnell.
Thank you, Chair. I'm happy to support these proposals. They're very good, very thorough. Just a quick question on page 4 of the report, the top paragraph. Children on a roll at a nursery school early years setting in September will receive an information pack in November. Will the information pack be available for any children that aren't in those settings? I imagine there may be some.
Yes, obviously we send the packs around to nursery settings and nursery schools, but everything is available online, and voluntary agencies that are supporting families will be able to access them as well. The school admissions team are always there on hand to help anybody who's got any queries. So if any community groups or anyone needs that information, they can contact the admissions team and we can point them in the right direction.
Okay, thank you. No further indications. Councillor Pearce, any? Okay, lovely. Well, thank you, Jill, and thank you very much, everyone. Yeah, are we happy to agree the report? Lovely. Okay, thanks, everyone. Good night.
Thank you.